Is there a possibility that we can have this like for like 10 later?
If you want, just let me know. It's flexible because
We have it 10 to 11 or 11 to 12.
just let me know. Just let me know. It's flexible for us, so just let us know. We just want to make sure you guys review the, if you have any questions or anything like that.
Okay.
Just let me know when you guys want to have it, and we'll just do it then. Okay. Alright? Just let me know please in advance.
I'll just get to it.
Okay, because I'm going to add the ethics.
I'm gonna let her know. No, I'm gonna be back in like hopefully 30 minutes.
Yes, sir.
I got called in to go in, so I'm gonna be right. The well-being committee.
Because otherwise it'd be like the press and hearing. Yeah.
So I have to.
Sorry, you have to go. Go do it. Hurry up. You have 10 minutes. Where do you have to go?
Everything.
Okay, hurry up.
Sorry.
Sorry, Miss. Yeah,
And she's in front of it. She had no idea. So he was explaining it. And then the associate was like, was the ring like in his pocket, or she opened it. They weren't even out to dinner. They were at her parents' house, and she was just like baking. And she's like, I don't know. That's the best thing. Yeah. I'm like, really, bro? But they're well, he knew. He knew.
Did you get his thumb drive back? I loaned Dr. Parsley his thumb drive. Okay, his pointer, so maybe he got it back. Okay. Very good, thank you.
He came back in for the pointer.
Did you give it to him because he loaned us his pointer?
I only got 20 minutes with you. Miss Lennon doesn't want me to have it, but I need to address what I need to address.
You're so pretty. Look at her.
That's his.
Look at her. I see you. I see you.
This is the one you just right here.
Anybody want to have more breakfast? Finish it. It's pesto bruschetta. It's good. Good morning.
I just checked these. Yeah, so it I did the
saying like I was waiting for the buzzer to go on. So she's like, I'm coming back with you. And the same thing was like, I'm coming back with you.
all these little ones.
Yeah. So she was saying, I'm like, if you get back. And then she's like, oh, tomorrow. I'm like, oh, yeah.
You know, I was I'm
telling her that. Oh yeah, perfect. Just like just
I had you texted her and I had the same idea. And I was like, man, no.
So she has like a couple hours. Like when you're not gonna don't worry at the first news whatever. I'll be there till like
Hi.
I realized I don't have your phone number after all. I think it got lost in all my text message threads.
You know, I've been praying about it and thinking about it, and I think it's a good deal.
Me too. I talked to my mom about it. She said not to worry about the animals, and cool. I think it's a good deal
I
too.
think you need to come
It's an
and
answer.
just look and see, and I have 2 rooms for you to choose from.
Yeah.
You can do whatever you want to do, but I think it would. I was liking it. I'm going, oh, this could be a good deal. So, and then I was talking to one of the faculty about the driving thing, and they said it doesn't include students. So
It does not.
yeah, that's what they think.
That's okay. That is okay. Just being that close would save. And stress.
Time.
And time.
You could study. You could study later. And then you could leave a little later and you could sleep more.
Yes.
I think all the way around will be better for you. But I was just thinking about it. I thought, you know, Lord, this could be a really good thing. And I wasn't even really looking because I told you the day before somebody asked me, and I was like, nah.
Yeah. So you're only today. It's Miss Lennon teaching. You're only going to be here for a little bit. But are you going to be in your office later today?
Yes, I will be. So I'm helping the CBC. So I've been up in clinic this morning. I came down. We're going to switch places, and I'm going to go back up at 11 something when all the CBC start coming in. So I'll be up there, and then I'm taking my mentees to lunch.
Okay.
For the seniors. I have 4. So you'll get a mentor faculty.
Okay.
So I'm taking mine to lunch, and then I'll be in my office then until about 4.
Okay.
Then I'm going to run home, change my clothes, and go to bed.
Okay. I think I can catch you in between a check by your
Okay,
door.
but let me give you my
Yes,
voice.
I will. Post it on here for some paper.
I don't know if somebody's receipt. What is this for?
I can write it up.
Weston Lakes, Henderson, that's buffet. It's 909-800-5595. What are you looking at?
Well,
Possibly. I mean, you want to move in as soon as possible so you can study for finals and stuff.
right. I have no idea. I was going to think about it, yes. But then again,
me, it doesn't matter.
because of finals. So I don't know if
You can start
a
staying.
lot. Yeah, that's what my mom was saying. She's like, you don't need to move a lot, just your scrubs, underwear.
Yeah, just so you have a place to be.
Yeah, so we'll talk more about it.
Okay.
Discuss it.
Hi, Brian.
Okay, so what do you want to meet today?
I have to go. I'm lecturing here for about 30 minutes. Then I'm going to back upstairs to help with CBC. So after CBCs, I should send a text message out.
If you're busy
Melina.
now, then we can talk after you get back in.
So it's Melina
Melina,
Bolt.
Steph, and Rose.
Oh, Marianne Bolt. Who else was there? I got an email from Lydia. Hang on a minute. Come on. Because Melina just emailed me. Actually, Katie. Let's see.
I don't want to intervene you. We can talk after the.
I'll go send an email later. Yeah.
How you doing, Miss Lee?
Good. Good morning. So, now this truly is my last class period, but I told Miss Lennon, hold off, can you come in at 20 after? So I have 20 minutes with you, and then I have to go back up clinic, and we're going to switch places. Actually, I'm going to stay a little bit and then go back up to help with mock board. But I need a volunteer for worship today. Okay, come on up. This is my story.
Flick us all.
Close your laptops, please. Can you take this? All right. How many of you guys are starting to feel the stress?
What's starting?
You've been feeling it, right? So, stress management. How heavy do you think this glass is?
That's like my weight.
5 pounds, 3 pounds, 5 pounds.
It's just
I actually think that.
Yeah, okay, so we probably have about 4 cups of water in here, plus the weight of the...
Say 3.5.
Okay, well, we'll do that. So, let me tell you, the absolute weight of this really doesn't matter. Okay? It depends on how long Lucille has to hold this thing. Okay? You're shaking, Lucille.
I'm just seeing her taking your time over here with the sword.
So if she holds it for a minute, not a problem, right? But if she holds it for an hour, she's going to have an aching right arm, left arm, both. And if she holds it for a day, we'll be calling the ambulance for Lucille. In each case, the weight of that is the same, right? But it's depending on how long she has to hold it. The longer she holds it, the heavier it becomes. Doing okay, girl? So that's how it is with stress management. If we carry our burdens all the time, sooner or later the burden becomes increasingly heavy. And we won't be able to carry on. As with this big glass of water, you have to put it down for a while and rest before holding it again. When we're refreshed, we can carry it. So whatever burdens you're carrying right now, let them down for just a moment and relax, and then pick them up later after you're rested. Because life is short. You ready to put it down? No. Okay.
You saw what she did? Okay.
So life is short, guys. Here's a couple of facts. Accept the fact that some days you're the bug, and some days you're the windshield. Always keep your words soft and sweet, just in case you have to eat them. Drive carefully. It's not only cars that can be recalled by their maker. If you can't be kind, at least have the decency to be vague. It may be that your sole purpose in life is simply to serve as a warning to others. Never put both feet in your mouth at the same time, because then you won't have a leg to stand on. Since it's the early worm that gets eaten by the bird, sleep late. The second mouse always gets the cheese. And when everything's coming your way, you're in the wrong lane. Birthdays are good. The more you have, the longer you live. You may be the only person in the world, but you may also be the world to one person. Some mistakes are too much fun to only make once. We could learn a lot from crayons. Some are sharp, some are pretty, some are dull. Some have weird names, and all are different colors, but they all have to live in the same box. That's your class. You all are different colors, you're all different shapes, you're all different sizes. Some are sharp, some are not so sharp. But you all live in the same box. Okay? Excellent. A truly happy person is one who can enjoy the scenery on a detour. Thank you. So, let's take a moment to put our stress away for just a moment, and let's pray. Do we have prayer requests? Praise reports?
Thank God the banquet went well.
It did. It did. Thank you for what an awesome job you guys did. I appreciate it. Whoever helped, and those of you that came and smiled at me, that was a joy. Any other prayer requests? All right, let's bow our heads. God, we're stopping to take a moment to let our stress go as we talk to you. Thank you so much for the many blessings that we have in our life. And you promised us that you would be with us, that you would carry us when we can't walk, when we feel the burden's too heavy. So right now we're just going to let it go and thank you for all the things you do for us, that you provide for us, and that you will be with us this coming dead week and into the next following week as we take our final lessons. Please bless the seniors as they have their graduation this coming weekend, and I thank you for the juniors that are helping with that as well. And now as we discuss some things, we pray that you'll be with us and help us as we come to some conclusions and some clarity in clinic. We pray in your name. Amen. Okay, so I got 20 minutes. I want to tell you that I went through every single one of these and I highlighted things that you wanted me to do. So I compiled it in a list. I wish some of you had put your names because they said, oh, I'm struggling with this, I need help. But I don't know who you are because your names aren't on there. So if you're welcome to come and let me know. Hey, I'm looking for, I haven't gotten this type of patient. I need this type of patient. If you tell me, then I can get to Jeanette and get those patients in your queue for you. So the number one thing that was on that list was the shortened clinic period. I get it. I hear you. I understand. Faculty don't like it either. We had no choice on this matter. But when you write your review, say that. Okay. Some of you are concerned that with the shortened clinic period that you didn't. What if you don't finish your patient? Then you tell the patient, you come back. Well, what if your patient can't come back? Some of you wrote. Then they can't come back. That's not your fault. It's not the school's fault. It's just how it is. This is a school. Things go slower. And patients know that. So don't feel bad about it. Just, oh well, I did the best I could that day. The number two thing was stressed out about finishing comps. Okay. So how many of you have your 4 comps? All the way up. I need to see it high. So about half the class have 4. How many of you, keep your hands up. How many of you within this next clinic session believe you will complete your 4? Raise your hand. Okay, so we're really close to 3/4 of the class looking like they'll be done by end of this clinic session. Okay, let me tell you how comps go. Because I got some lengthy things about it's not fair that my grades drop and blah, blah, blah. Well, let me tell you how it works. Your competencies are only a certain percentage of your grade. I believe it's 30%. Okay? So if you're missing, and let's say you have 10 comps that you're due, but you did 9, you're going to get 9 out of 10 out of 30%. It's a very, very small percentage of your grade. It may or may not change your grade at all because you got the other 70% that you're going to get scores for. Okay, so somebody else said, why do we have to do these comps? It's not reflective of my clinical skills. And my response back to that is, excuse me, Your clinical skill does not involve anesthesia. Your clinical skills does not involve taking x-rays, does not involve evaluating your x-rays, cleaning a denture, using an ultrasonic. Everything you do up there, all of these comps are part of your clinical skills. It's part of who you are as a dental hygienist. And those are things we expect you to be able to do. And then someone was saying, well, what if I don't finish them this quarter? Okay, if you don't, then that part of your grade, you get 3 out of 4 or whatever you get. It's going to be minimal on the change of your grade, so don't stress. What I want you to do is 100% on that 30%. So go for all 4. If you have 4, I'm going to tell you, don't stop. Keep going, because that's going to stretch out into the next quarter.
Would we have to make up that 4th one next quarter?
Yeah, because you're going to have all of them by the end of that quarter. So yeah, you will. And we have people. Do we have people doing it? Yes. Do they still pass clinic? Yes. So don't stress out. It's just a small little portion of it.
Correct me if I'm wrong, the anesthesia exam, won't that count for some of our comps if
Yes.
we pass one?
So if you pass both of those, both of them, it will count as one of the 4. Okay, but you have to pass both. So if you pass one and you don't pass the other, it does not count.
Not even at the half.
No, no. It will. You have to pass both in order for it to count. And in the end, you'll have to pass it anyways if you don't pass in order to finish and pass junior clinic. So you'll have to get it done at some point.
Are we only doing 2 injections?
2 injections. And you'll roll the dice for that, but Miss Lena will tell you all of that in her time when she comes. It's random. So you'll roll the dice and you'll get this or this injection.
My instructor in the last lab, she was saying don't stress out because during the summertime the juniors are
You're
the main,
primary, you're
so
it, we're it.
seniors, so
Yep.
we have more time spent on it.
Yep. Okay, the second thing is somebody wrote on a radiographic evaluation comp, how many points can you miss? And my answer to that is it varies depending on how many points there are in that particular competency. So you have to score, I believe it's by 80%, 80%, 75 or 80%? 85% on that particular one. Then, so 85% of how many of the points there are. Depends, if you choose someone that has a ton of things that are on their list or a lot of fillings or whatever else compared to someone that has 5 less than you, then of course you're going to have more points and you can miss more. So that's how that's scored. Now someone said they're having really stressed out about an FMX comp on a real patient. Try one. That's all I have to say is try one. If you don't get the comp, try another one. Watch your watch your Axiom email. Dental students are constantly not wanting to take x-rays. They'll say, FMX comp worthy patient on this date, if you're available and you can take it, take it. Yes, email them back.
FMX comp word patient. Can't it just be any patient?
No, it can't, because if they are missing a bunch of teeth, like they have a full upper denture or whatever, that's not an FMX word. You have to have teeth in there. So you can have missing teeth, but you can't have a whole lot of missing teeth. So
And restorations don't matter.
no,
Like, if it's
restorations don't matter.
Okay.
Okay. The next thing that was high on the list was instructors. And they're saying, oh, we're short instructors. I have to tell you, this is the most instructors we have had on clinic in the last 5 to 10 years. So I don't know what the complaint is. We used to have instructors, we used to have 5 students per group. Period, straight out. We have more now than we have ever had. So you're lucky in that sense. So if you're asking, well, we need more faculty, we have a lot compared to what we can take. Calibration. I understand the concern about calibration because we have 5 new faculty up on clinic and they're working really hard to get calibrated. They're doing really, really well. I know you're doing mock boards up there, CBCs now, and I saw one faculty sitting with a new faculty explaining how this works and how to grade it. So I know we're working on calibration. Be patient as with us as we are with you guys. Another thing is, students were saying on their little papers that they wrote, have empathy with us. We're new. all the faculty know that. We know this is your first real clinic. There are expectations that we have, and we hold them fairly high. We've lectured on them. We've done this. I've had people ask questions that I think are really basic. It's stuff you should know. Like, how do I attach a note to Axiom? We've had that on a quiz, and yet I still have people going over to the right side and attaching a note there. Where does your note attach to? To your treatment or your attendance. So you have to highlight the attendance, highlight the treatment plan, and right-click, add note, general note. But I still have people going over here on the right side to put in their note. That's when I'm not going to be patient. You've had it on a quiz, we've talked about it, I'm talking about it again. That's when I'm not going to be patient, because I'm like, you should know this. And you did it for your junior clinic. So now we've been 6 months doing this, and you still don't know that? That's when I become agitated, okay? But we understand that you're learning and you're new, and hopefully we're trying to be patient. Someone else saying, instructor's not staying the whole time. When is that happening? And if it's happening, I need to know that. Okay. Are you having instructors that are leaving early that are not completing you? Somebody wrote that. Tell me. I need to know who that is so we can talk to them and say, hey, you need to stay in whole clinic. Unless there's a doctor's appointment or a meeting, and I totally understand it, then they should come to one of us or me, since I'm the clinic lead, and tell me, hey, I have a doctor's appointment, I need to leave early, I'm leaving my group, can you finish signing out notes? Then I can do that. But if they're just taking a hike when you're not finished, that's not the deal. I mean, last week, I had 10 minutes for lunch. Because I have to get right back up there too. So, yes.
I haven't noticed them leave early, but I've noticed some come late. So like we already have our patient and we need to be checked and they're still not there.
Okay. Morning or afternoon or both?
That was morning.
I thought it happened
Both? Okay. I will talk about it with the faculty. So, late in the beginning.
Because even if they show up like right at 9 or 9:05 or...
They shouldn't be, and I'll tell you why.
Like we
Because you should have your huddle.
Yeah. Oh, I've never had a...
Okay, how many of you are not having huddles? How many of you with your hands up, raise your hands, have had me as faculty?
That's the only time we get
That's the only time we get a little.
Are you serious?
No, Miss Vidal does.
Miss Hayden does it.
Miss Hayden, she prays.
And Miss Reyes is doing it too? Is not doing it. Okay, she's new and may not know. So let me talk to her. Who is that?
Miss Edie.
Okay, so she's doing it.
She's not doing a group.
Okay.
She comes and checks in on you. She says,
Okay.
what's the
Who else is not doing it so I can...
Miss Armstrong.
Okay.
If she's late and doesn't... and does stuff.
Okay. Yes.
When you say a huddle, isn't it meant to be a grouping so we know what each person has?
Exactly, because that's what I tell my group. You know what's going on, and you know why I'm standing at Daniel's cubicle for 15 minutes, because he's doing 5 injections.
Because I already said my patient, I'm telling her, I know she checks with me, says, what are you working on today? But I don't know what anybody else is.
Okay. Do you think that's important, or you don't care what somebody else is doing? Okay, that's my purpose for that huddle, is that you know what other people are doing, especially floaters. So floaters can know who in their group that they can help or supply. So I will talk to the faculty about that. Yes.
So I mentioned that because you have extra times for me. So our clinic going to start at 1, but the patient, when they are there, so one of them came around 12:45, and
Then I tell the patient, excuse me, but I have to have my group huddle, and leave the patient there. It's okay, absolutely, because it's critical for the faculty to know what you're doing and how they can help you and what you plan. Because what I want to know in a huddle is, do you need x-rays? Because if you're going to be gone from your chair, I need to know that. I need to know what comps you plan to attempt, so I know how I can help you. And I might tell you, you know what, I'm going to be doing an OHI comp at the same time as you're going to do your x-rays. And so, the same time that you're doing your anesthesia or other things like that. So I need to know when to move that around. Can you do that instrumentation comp and later on during your time so I can get everybody else? Okay, I understand also that there's been a lack of patience. For the 2 weeks that Jeanette was gone, nobody scheduled patients. Unless we brought them in for that kind of thing. I apologize. Jeanette was furious when she got back because she left specific instructions on that. So hopefully that will not happen. However, we are going to make some major changes in this summer. That's not individual hygiene department's fault. We are actually going to be moving clinics. We're going to be out on the main clinic. We are also going to have a new clinic coordinator. Her name is Adriana. We'll introduce her first day of next quarter. We're going to have a meeting on Monday afternoon. Then we'll take you on a little field trip, show you where to find all the supplies, do all that, meet your coordinator, and get familiar with the chairs over in that clinic. In fact, where they're moving us is where hygiene originally was, and they moved us to South Wing. Now they're moving us back over there. So, Jeanette got a promotion. She will be moving into the new wellness clinic that they're starting. So, they take all the good ones, but I think Adriana will be a good one for us too. And so we'll get to know her and, of course, be patient with her as she starts. But Jeanette's a good teacher, so she'll hopefully teach her how to do that. Clinic for summer quarter. You will have clinic 4 days a week. You will have clinic every day except for Tuesday, a half a day. So you're going to be busy. Okay? If you think you can't get comps, you will get them by now. Don't stress out. Somebody said, we need more floaters. Well, I'm going to tell you this. Floaters were only for junior clinic for kids. They are instructed to book every single one of you. So you need to learn how to function without a floater. In private practice, oftentimes you don't have someone. So you're going to learn to chart your data and do all of that. So when you're asking me for more floaters, no, there's no floater deal anymore. That was just for the kids. Now, if they start booking you, every one of you should be booked coming summer, hopefully. Yes.
When charting our own stuff, can we keep our clipboard and our pen and write with our glove keeper?
Yes.
Okay.
Yes, you can. But know that that's dirty.
Yeah.
And it never goes on the clean thing, because I had someone twice last week put a dirty thing on a clean side.
Okay.
So please make sure that you're making sure that that's dirty and stays on a dirty tray, dirty whatever. And then when somebody happens to float and they're going to chart, that they use a gloved hand and a non-gloved hand to enter data.
So if we're by ourselves, can we just enter it when the patient leaves?
Yes, absolutely. Yeah, you don't have to enter anything before. So that's all later on time. Yes, do you have a question? Anyone else? All right. Grades. Somebody said, I think our comp should be updated weekly. Do you know what you're asking Barbara to do? She can't do that. She takes them in lumps and does them, and you'll get the comp sheets coming back out, a list pretty regularly in the summer, probably 3 times in the 3 months, so once a month. She'll try to update that. Especially now, she's heavily doing pinning stuff, and if you haven't gone to pinning or come to the reception that's going to be there, you will see what kind of work she's doing. She is swamped right now, so don't ask her for a comp update until after pinning.
It's like planning a wedding for 36 people, just so you know.
40, whatever. So, anesthesia. Somebody said anesthesia is not enough time to practice. I don't feel confident. Okay. So, I'm going to say
would you like
have
my answer?
plenty of time in the summer. because you are going to have lots of clinic time, and you'll get through that.
And is it a normal developmental stage to feel confident right now? Nope. If you feel confident, I'm worried. Very worried.
Yes. So someone else wrote prep for OSCEs. How are we going to prep for OSCEs? I'm going to tell you your summer junior promotion OSCEs will take place in August, but it is everything that you're doing right now. So we're going to test you on, can you set up your chair? Can you break it down? How are we going to practice for that? Can you take vitals? How are we going to practice for that? Can you do an EOIO? How are we going to practice for that? Can you identify oral path lesions? Oh, I'm taking oral path right now, and I'm looking at lesions in the mouth now. Can I treatment plan? We've had 2 treatment planning lectures now, correct?
Next one's tomorrow.
Okay, and then you have a 3rd one tomorrow, which you will get your laminated sheets.
I believe so.
Okay, and anesthesia. That's going to be another one of your things on your home. So where am I going to get time to practice for those OSCEs? Every day you're on clinic. Don't stress. Somebody else said finding patients, because you see seniors stressed out. Your senior clinical coordinator is Mrs. Ellington. In senior seminar, she will go over all of that. She will tell you, you guys will have screenings where you're going to pass out flyers and tell everybody to come in on a specific screening day. You know what? God has always provided. We have never sent anyone to boards with no patient. Never. It might not come when you want it, but you'll get it. So have faith. And if you don't believe it, hang on to us. Faculty know it will come. You'll get your patient. Somebody said, can we have some music on clinic? Yeah. And you know what? We used to. We used to play the same music through the whole dental school. It was kind of elevator music, but that's okay. I have not checked on that, but I don't know if there's a specific reason why we stopped doing that. But I'm wondering if we can, now we're going to be on that clinic, so it's going to be different. I'm wondering if we can plumb it through that one. But I will check and see why that stopped. Because we used to play elevator music here a long time ago. So, all right. Who has the sheet here? Is everybody here today? No. Not here. Okay. Well, I think it's going to be okay as far as I looked. If everybody is here today, then everybody will pass junior clinical seminar. Okay? So I had some people stressed out that they weren't going to pass. If you're here today, the way I calculated it up, you saw me changing stuff. If you were online on Saturday night, I kept changing stuff around and plugging in numbers and pretending if somebody wasn't here whether they were going to pass or not. If you're all here today, you're all going to pass. So don't stress. And somebody else said oral hygiene aids. I don't know much about them. Where am I going to find that out? In the summer, you will be taking a course that will involve heavily on oral hygiene. You will have seminars that are reps from different companies coming to do lunch and learns for you every single week in the summer quarter. And they will bring their wares and give you samples and talk to you about their product, and you'll get to use them. You will also be creating a product journal. So you're going to try a product, you're going to tell what you liked about it, what you didn't like about it, and etc. And that's an assignment that you'll have in the summer, I believe. So it's a product journal. So you will get more experience with oral hygiene aids. Did I cover what everybody wrote enough? Yes. Do you need anything more? Okay. Well, yes.
Can you explain the finals week clinic?
Okay. So the completion clinic, if you have a patient that has an open treatment, in other words, you collected data and you haven't started scaling, or you collected data and you're partially finished scaling, you need to finish up that patient. That's that Wednesday, June 5, in the AM clinic. You will have a whole 4 hours. If you have not completed your competencies, you are expected to be on clinic. So I don't expect anyone to have less than 4 competencies and not be on clinic. Okay, so you're all expected to be there if you don't. That's the time when you have faculty full attention, so we won't have a full clinic, but we'll have enough faculty to go around for you to go find comps wherever you need to be.
So, for example, my brother, I had the 4 SRP quads, and I did 1 quad. Do I have to be there June 5th to finish the second quad?
If you want to complete the quadrant, you can do that. Okay. But we don't want these open treatments where you have 1 more session and you're done, kind of thing. Okay.
If you miss a clinic, will that day make up for the day that you missed?
Yeah. If you missed a clinic, you're expected to be on clinic too. Okay. Sandra?
I haven't incomplete patients, but I know they can't come.
Are they going to come back?
No.
Never going to come back.
No.
Okay. We need to talk about that with Jeanette so she can pull that out of your family and say, we need certain notes in here to say the patient will not be returning. Okay.
So if we're not scheduled a patient and we already have the 4 comps, then we don't have to go.
Correct. Sarah?
So you mentioned 3 because on 6 in the morning we have all that.
And that one, I understand. But that's the day for our finish completion of our clinic. So, anyone else?
If we have the 4 comps, can we still come in?
You may, absolutely. Okay, you may. If you feel like you want to finish up or whatever you need to do, you can do that. Jeanette's ready to schedule. She's got a couple of you already in there. If you talk to her or move stuff around, you can do that. All right, Sandra?
So if you finished your comps and you finished your patients, you don't have to come as a floater? Or
Correct. If you want to come and help, like Sunshine, that's great. Appreciate it. Yes.
If you're starting a new patient on Wednesday, barely starting new, that has to be completed by June 5th? That one?
Let's see what you have. Okay. We don't want people, because that break is over a month, almost a month from now. So this Wednesday, it's more than a month actually. So to leave someone hanging there, not good. All right? Nope. All right. It's all yours, Ms. Mandy.
Alrighty. So, OSCEs of all various kinds. Oh. Is this your new water glass? So, when we did the partner assessment on each other, I was looking for, are you really good to be a very effective safe starter for an adult patient, which was the goal of last quarter, right? So, same idea with anesthesia. Same idea with the lab OSCE. Like, did you get the stuff for the end of this quarter? Alright, come out of here. Let's see. See if it'll talk. So, same idea with local anesthesia. There we go. Okay. Actual up-to-date technology kind of threw me there. Same idea with local anesthesia. So, we do not expect they're going to need you surely because they're going to be checking people out right now.
They told me to text me at 11.
Okay. So, the level that we expect you to be at with local anesthesia is not necessarily that competent. What you missed was me saying if you feel confident doing injections, then I'm scared. I'm not just worried, I'm actually kind of scared. So, we expect that it's going to be stressful. We expect that it's going to be, you'll be shaky. We expect that you're going to be freaked out. That would be a normal developmental stage. And that's all okay. And this is one of the reasons we do it on partners, so that you're not freaking out a patient too, right? And so, because we have to just stand there and watch you, so we can't like walk you through it. So obviously the better you can do your practicing, let's do this. The better you can practice on clinic and with each other through this whole quarter, the better things go. It used to be that lab that we did in the first week was just me. And so I would barely be able to run you through 4 injections times 4 people times clinics. And so some people this week would be getting pain control block, but you guys had the benefit of having it the first week. So you've actually had more time to practice after the lab than years past. So we started doing that a couple years ago. So good news with this, remember me saying this is formative, this is not summative, this is not a do or die. Doesn't mean you don't take it seriously, right? I want you to be really serious about it, have really reviewed, feel as comfortable as possible going into this, but it's not going to count against you if you don't pass it, right? So you're not going to go home and have the death spiral of, I suck, okay? You're just going to say, okay, I'm going to review some more. Just, you know, step back from the edge of the ledge there, it's going to be okay. So, like I say, take it really seriously. It'll count for you as one of your competencies, so that's awesome. As far as clinic competencies for this quarter. Okay, so it's not considered a local anesthesia competency by itself. So you're still going to have the same number of local anesthesia competencies, but this will count this quarter as a competency to help you along. We will remediate it if you didn't pass it so that you get more practice. We typically do that at the beginning of next quarter. And we will be doing the pain control block together again at the beginning of next quarter. So you'll have the great, wonderful half. I believe we're just doing a half day this time of injections again. Okay? So you'll be getting them again. All right, so anesthesia skills competency. Are you on the track to being competent for that? Right, so these are the benchmarks of how we do it. So every time you're like, oh, I can't do this. No, you just leveled up. It's okay, you can do this, right? It's going to be okay. So if you pass, it counts as one of your competencies. If you don't pass, again, we are not concerned so much about, you know, oh my gosh, you're way behind, but we do want to remediate you, and you'll get some extra practice during clinic. That's your responsibility to seek that out. Okay, here's a schedule. It's posted in Canvas. So take a look. Somebody make sure I can see it, that you can see it in Canvas. So go to clinic. In fact, everybody go to clinic. Go ahead and open the PowerPoint.
Pre-clin lab or lab?
It's in clinic.
Oh, in. Is that your proof that you drew the random cup?
It's the sorting cup. I don't have a hat. I have a cup. Sorting cup.
And it's under modules?
Yeah, it's in the local anesthesia module.
What if I'm not on there?
Oh, then I blew it.
Then you're with Kevin.
Is someone on here twice?
All right. Sorry.
That's your punishment.
My name is up there.
Yeah.
That's it. So you guys come see me after. I'll fix it. Okay. Sorry. Okay.
It's under the local anesthesia modules.
Under local anesthesia module. Should be at the top. In clinic.
In clinic under local anesthesia.
All right. Anybody able to see it in clinic? Nobody else is looking.
I'm looking right now.
Okay.
So I'm in clinic under modules and under local anesthetic.
Right there.
Oh, it's a
Tough thing.
PowerPoint. Oh, I was looking for just a PDF document, not a PowerPoint.
No, PowerPoint. Okay. All right, I have not lost the skills. That's good. Okay. I'll fix that. Sorry.
I'll post it on the Facebook page. But where's that PowerPoint from? It's the
Canvas.
first PowerPoint in
Local
modules.
anesthesia module.
In what class though? Clinic.
Clinics.
Oh.
Junior of competency.
Okay. See if everybody's on the page. Everybody good back there? Okay, so you're going to give 2 injections. So one partner will do the IA, the other partner's going to do the PSA. How do we decide? We roll dice for it.
Wait, one's doing the IA and one's doing the oh wait, are we doing 2?
So we consider that those the 2 major injections. So one each of you will be doing 1. The second injection is either nasogrador or infiltration. Right? Those are the basics. If you can do those, you can pretty much get people numb, right? So here's the thing. What side am I going to expect you to do this on? Right? Because that's what you're practiced the most at. I'm not going to throw you under the bus and suddenly say non-dominant.
Within the IA, are we doing the lingual on the way out?
Yes. Doing lingual and buccal. It's all part of the injection. Yep. Okay. So, IA, lingual, buccal. You've got 30 minutes to get 2 injections done. Achievable, yes? Okay. So, here is the strategy though. You're going to get your wooden swab tip. You're going to get it amply topical, and you're going to palpate with it. Yes? Because then what are you doing? Right? You're already putting your local topical anesthesia on there, so it's saving time. We start your time when either you palpate or you start loading the syringe. So the trick is palpate first with topical on the swab, and then you're doing double duty, and then while the topical's finishing its work, you'll set up the syringe. Okay? So you'll roll for the second injection. Could be any of those 3. So be prepared to do any of those. We're going to be dominant side. Okay, so what I do need is anybody who I've said, wow, this injection is difficult, you're going to let me know today before you leave this room that I did that so that I can actually put you down on my list of, hey, so like Miriam is not doing an IA because why would I torture her TMJ as I have 3 other previous times, right? She's had to go home, probably do drugs for and say, it's helped me, right? I appreciate your patience with us. So, other than Miriam, if I have said to you, gosh, this one's challenging, or your anatomy is a little bit atypical, you're going to come before you leave today and tell me. I'll put you on the list, and then that will determine what the other person's going to do to you. Okay? So, here's the deal. If you can get your chair and everything, and your patient's head, and the light in the right position before you start, you've probably experienced this. Oh my gosh. Suddenly you can see and you can get the job done, right? So please, 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 first thing, you're going to get the patient in the best position for that injection. Okay? And for your particular body size and whatever's happening with the chair. So, the other thing is getting the grasp. If you don't have this grasp yet, this week you're going to figure out how to do this grasp. This is not optional. You just got to get this done. It just makes it so much easier to land a fulcrum if you are like this, with your syringe right there in the webbing, just the last part of your thumb in the ring, and the syringe is coming across your arm, not straight ahead. Yes?
Sometimes I feel it's impossible to do a fulcrum. Like it's
Right,
just-
this will help fix it. So that's your week, this week. You're going to take every chance you get and you're going to go set fulcrums down. Work with an instructor.
Are we going to be like, is it generalized? Do we use the winged syringes or the?
Makes no difference.
Okay.
Same
So
grasp.
you can do it.
Same difference. It's really your index finger wrapping around there that makes the difference in your stability. So if your index finger's not wrapped around, then you're not going to feel stable no matter what. Wings or not.
And when we're going contralaterally over the premolars, it's okay. Yeah, I answered my own question.
Okay, good. I love that. Critical thinking in action. Right? So when you're doing the dominant side IA, it's challenging. If you have this approach, you're already in an angle to come contralateral, right? So palm up, I want to see your palm up and your hand in this Y. If you're doing this and you're trying to aim the syringe ahead of you, then you're in big trouble because you actually look at the difference in how close you are to the end. So you're just setting yourself up for not being able to touch. Kinesthetic thinking. Okay, good. Okay, so think about the fact that we've got 3 nerves. We're trying to get the inferior alveolar, we're trying to get the lingual, we're trying to get the buccal. Right, so I really like this looking from above. So making sure that you're really knowing that this is the coronoid notch. The last bit of bone until you fall out in the cheek. If you have not felt that reliably yet, again, this week, get a partner, go up there at a time when you can have a chair and palpate until you fall off into their cheek. And that's the coronoid notch. And then this inside ridge is the internal oblique. So this is the external oblique, this is the internal oblique. And we're wanting to put our thumb right next to the internal oblique, covered up. Lingula's back here. And so your deposition points for your IA is way back here in mandibular sulcus, and then it's out here to catch the lingual nerve. If we're back here, you're going to be at pretty much this height here for your IA, and then as you come out, you're going to catch the lingual nerve. Does that help with visualizing? Okay. So, buccal nerve. Remember that we are going to slide our thumb out first and then come out of the tissue. Here's where this buccal nerve runs between the external oblique and the last tooth. So we're going to catch it along there. Making sense? Okay. All right. So, thumb over the internal oblique. I know this is Dr. whoever's thumb, maybe Dr. Kroll, one of our former faculty. But really, this is my horrible mouse sketch of a thumb.
That's what I see.
That's what that is. Okay, so that's where your thumb is going to live. It's not going to be out here at the external oblique and way low. It's going to be up here, parallel to what? The occlusal plane of the?
Not maxillary.
Maxillary.
Oh, maxillary.
Maxillary occlusal plane. Sorry, mandibular occlusal plane.
Mandibular.
Lost my mind for a moment. Mandibular occlusal plane. You were right. I'm so sorry. So, mandibular occlusal plane. Keeping this parallel with the teeth. Here's your raphe. Right? There's your lingula. We're going to try to go just above or the level of the lingula. Come in here and touch gently on the medial portion of the ramus. Walk it back. Hopefully just a couple of steps. So, see this height marked here? This is what we would say would be the deepest portion of the coronoid notch. Since we have started doing the up, down, in, out, oh my gosh, so much better. You wind up about 1 millimeter, maybe 2 higher, and you don't have to walk over the lingula to get to the spot. Your patients like this way better. So, by coming down and stopping at that first dip, you're going to be able to cruise right along and get into that little groove there, that mandibular sulcus, and get for sure above the mandibular foramen and get them down. So it's going to be 1 centimeter above the occlusal plane. How many millimeters is a centimeter?
10.
10. So think right now, how many millimeters is 10 millimeters? What distance is 10 millimeters on your probe?
5.
2 black stripes, right?
On the
Yeah.
No, on the
Neighbor's
probe. On the UNC probe. It had any in it. Okay? 2 blacks, the second black stripe on your UNC probe. How far is that? Feels pretty far when you look at it that way, right? But you want to be 1 centimeter above the occlusal plane of the mandible. Okay, so if you've been fudging to go down because you thought that's too high, that can't be right, it's actually correct. So thumb parallel with the mandibular occlusal plane, sorry sunshine, and we're going to try to get that guy really lined up. Here's our target spot. You want to be right in walking so that your tip of your needle is over the mandibular sulcus where that nerve is living. All right, so what does that look like? There's the raphe. Has anybody not actually identified a raphe yet on a patient to this week? Does anybody have an awesome raphe? Right, so you guys will get together. All right, so you're going to see a raphe. So the Malamed technique, or it's actually Halstead technique, it would be pretty much right next to this raphe and in this little groove. You guys, however, are going to really think about the internal oblique ridge and think about getting your thumb over that. So this person is not in the internal oblique ridge. Where's their thumb?
On the corner.
They're on the cornoid notch. So they're too far away. Look at that distance that they're having to decide where's my penetration point. Right, so we're going to put your thumb right over the internal oblique, and then you're going to look at that and say, wow, I only have like 3 millimeters to decide. Makes it way easier. You're going to then think about, there's our triangle, so the occlusal plane, the raphe, the internal oblique, and that's that triangle. You want to be usually about halfway up, depends on the person's anatomy. And you are actually going to be a little further away from the raphe. So slightly more lateral because we want you to touch to be able to walk. Okay? We don't want you too close to the internal oblique. What happens if you're too close to the internal oblique?
You could hit the internal.
Right? You can hit the internal oblique. You could have to walk for, no one needs to walk a mile around somebody's periosteum. Right? Okay, so parallel to the mandibular occlusal plane. This is going to put you so that you can see where is that lingula. If you're parallel to the maxillary, then it's going to aim you down, and you're not going to be able to walk off, and you're not going to get the patient down. Because where's the nerve when you're that low?
In the bone.
It's already in the mandibular canal, right? So it's protected by all that really heavy duty cortical bone, and you're just not going to get anesthesia to it. Okay, so mandibular occlusal plane, make sure you are really, really parallel, and that's going to aim you right above the lingula, so you get into it.
When you're palpating and you find that internal oblique, don't move your thumb 1 iota once you're there. The problem is it gets wet and then you end up sliding out, or you point down, or wherever else, because your thumb should be sitting on the internal oblique, which is where the deep tendon runs through. If you put your thumb there, you will protect that deep tendon, and you will never put your needle through your thumb. So you will never put it through the deep tendon, so you will never have trismus.
I'm going to borrow you for a second. Let me stand up here. Okay. So, you know how specific my directions are because I have thought about this for thousands of hours, right? I'm not going to hurt you.
Okay.
Turn around this way. Okay, so here's the thing. When you're palpating with your thumb, right, you patient wide open, I always want you guys to have your middle and ring finger on the back of the patient's ramus. Because when I come in here and I'm palpating with my thumb, how stable will I be? Really stable. So I want you to hug the ramus. Okay, so I don't want your thumb pointy like this. I'm digging my thumb into the RFA. I want you to actually be a little flatter this direction, and that is going to keep you on the internal oblique, and you won't slide off. Okay? Why does she keep making move my fingers up under the patient's ear? Because it keeps you stable. Here's the other thing. If we ever get to teach you gout gaits, then you have your finger to stick into the intertracheal notch so that you can aim at that. Later landmarks.
We're going to do
You
that?
guys talk about gout gaits in the class?
We're going to do that?
We talked about it.
We talked about it. So if you have a really hard patient and I have to come over and help you with a gout gait, you'll be learning it. So, middle and ring finger on the back of the ramus. And it keeps you parallel with the mandibular occlusal plane. And keeps you nailed down to your spot. Thank you. Okay, so thumb parallel to the mandibular arch, mandibular occlusal plane. Feel for that coronary notch, that part where you slide out into the cheek. You're going to slide up to the maxillary occlusal plane. You're going to slide down to the first dip. As soon as you feel a dip in the coronary notch, and you're going to stop, and you're going to stay at that height. And keep your thumb parallel. At that height, with your thumb parallel, you're going to slide into the RFA. And then when you slide out, you're going to slide out and stop over the internal oblique ridge. You protect the, right, don't slide back out in the cheek. We're all going, stop, don't do that. Right? Okay. You'll do this. You'll place your topical with your wooden swab tip. What are you checking with the wooden swab tip?
Squishy spot.
Squishy spot. What should you be next to?
The ring.
The rough
The roughy. Do I care how close you are to the roughy right now?
Have your thumb.
What's under your thumb?
Between the two.
And what can we feel? We can't necessarily feel the tendon itself. What are we feeling? Oh, internal oblique ridge, right? Which is bone. So I should be able to feel off the end of my thumb and feel squishy, but also there's bone right under my finger. And you, if you push gently, will see the tissue bend over the internal oblique. So if your thumb is out here and you push, wow, it's kind of hard here and it's squishy here, and then the tissue bends, it's like, yeah, because here's the internal oblique. So if it's soft tissue's bending over the internal oblique, your thumb slid out. Fix it. Okay, so you'll feel under your thumb the external oblique, the coronary notch, and you'll also feel that inner rim of bone, which is the internal oblique. The video is posted in local anesthesia, and so watch that.
Yeah, it doesn't work.
All right. Remind me to play that later. We'll come back to it. Okay, so if you land too soon, or you have to really close the angle to step, you could be too low and you've run into the lingula. You could be too lateral and you landed really close to the internal oblique and now you have to walk half a mile around there. Or you're way too far lateral and you're actually on the, whoops, where's my little X? There you go. And you're actually on the front surface of the ramus. What injection do we do over here?
Long buckle.
Long, but we did the buckle. We don't want to do the buckle right now. We want to get past there. So if you just go in there 3 millimeters and go thunk, that's probably not recoverable. You probably just need to penetrate again. Start over. If you land 4 or 5 millimeters in and you are sure that you're past your internal oblique, then you just landed too soon. So you're a little too close to the internal oblique, and maybe consider restarting that injection, because again, your partner will like you better if you don't walk the half mile there. Okay, so this is what it looks like on the skull. So here's the coronary notch, here's the internal oblique. Here's covering the internal oblique. Here I'm hugging the ramus, right? Fingers behind the ramus, thumb on the front. Fingers behind the ramus, thumb on the front. Penetrated off the end of my thumb, just past the internal oblique. And I'm going to touch, walk, 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 hover over the sulcus. Make sense? Okay. And again, don't let your thumb slip off your landmark. Ah! Okay. So, if you land too soon, but it's not too terrible, like you got in there 5 or 6 millimeters, and you think, okay, I can probably still do this. Remember, we're going to come out a little bit, pull the syringe out a little bit, swing so that you're going more towards the midline with the barrel of the syringe. Because, sorry, it's from Elements, but why did we do mirror image? I don't know. Come out, swing towards the midline, and then go towards the distal again. Penetrate a little bit more. And you should be able to walk along and be able to get deeper.
You do that when?
If you land pretty soon. And you feel like you can't get off. Boom. So you come out part way. You'll do what we call close the angle. So you won't be so far contralateral. You'll come a little more towards the midline, and you'll go back. You don't just keep cruising back forever. You go back till you think, okay, I've made significant progress. I'm pretty close to the mandibular sulcus. I'm going to go ahead and go more contralateral touch, and then hopefully just take a step or two to get there. Question?
If we did like the perfect injection, how many times are we giving the anesthetic pathway and walking as far as like?
It would be lovely if it was 1 or 2 times.
Oh.
It would be bad if it was 10 or 12.
Yeah. Okay.
It would be very bad. Okay? If it's 3 or 4, that's fine. As you get more experience, you should be able to touch and walk off pretty easily. Okay. Say, oh my gosh, don't do this. Right? Don't go that far. I'm sure he cut the needle off. He didn't really do that. We're not going to hub it. If you're past 3/4 of the depth of the needle, stop. You need to back up a little bit. Have I had a patient that I had to go 7/8 on a regular IA? Yes, I have. The guy was about 6'4", African American, very flared jaw, which tends to be more common with African American patients, and it was the only way we could get there. Okay? None of you are that. I have not seen anybody. I have had a tiny little Asian woman with a really flared mandible, and we had to go pretty deep.
Yeah,
But none of you are like that.
It was like forever. I almost went to the office because his jaw is so big, and I had Kayla, so it was like way bigger.
Right.
I don't feel like you're doing it wrong. It's just different anatomy.
Yeah. Okay, so this would be, I'm too far, I'm probably going off the back of their mandible. Now what? What's my danger? Facial nerve paralysis, because why?
Running right there.
Running through what? Through the parotid. Remember that parotid wraps around. Think about biting into a really nice, big, juicy lemon. Where do you feel that right now? That's where your parotid is, okay? So, please be cautious. Active learning. I caught that, right? So be cautious that you're not going to over-insert. Be safe. Okay? So unless you have walked, and made a little step, don't keep going. 6 more millimeters, made a little step, and you know you're over the mandibular sulcus, you are not safe to inject. Okay? This is why we use a short for this injection, doing this technique. Because I don't want you back there fishing around near the facial nerve, near the parotid. Okay, so dominant side. So you're going to get the patient low and semi-supine. So they're sitting up pretty far. You're going to sit in front position, so 8 or 4. And you're going to have this hang loose technique, and you're going to stick your pinky out and be able to come in and just set your pinky down, land on the opposite side of their jaw, palm up, palm facing you, whichever makes sense in your head. And you're just going to, as you swing in, you're just going to lay the barrel of the syringe in the commissure of their lip. And that'll give you a little stability till you can get your pinky down. Then when your pinky lands, you should be right next to the tissue. Okay, if you're teeny, teeny, tiny, this is sometimes harder. But we will work with you on your fulcrum. You have to have this person's thumbs a little far in the ring. They need to be right near the end of your thumb. That lets you swing your pinky forward to be able to land. Okay, so got to palpate the structures correctly. Got to keep your thumb on that deep tendon internal oblique ridge, hugging the ramus. And most of the time it's because your thumb's not parallel or you slide off of your landmark with your thumb. And the other thing is you have a bad grasp and you don't land a fulcrum and you're sort of floating around. I don't know where I am and you're scaring me. It's back to my blood pressure, don't do it. Yes?
Do we have, can we get like little grips to go in there that like will fit our thumbs if we have little small thumbs?
If you are really doing a good grasp with this part of your hand right here is controlling the syringe, and that leaves you without having to worry about holding the syringe with your thumb.
Just like pushing down, I feel like my thumb just slips out if it's like on the edge like that. It just...
Get with us, we'll work with you. Okay, so here's your script. Okay?
Do we have to say that?
Pretty much say that. Okay? There's your script. That's what we want to hear. Makes sense when you read it, yes? Good. Okay. All right. We'll come back to the palpation of the IA video at the end. Let's talk about this stuff. Okay. PSA. You have to get back far enough so that you can get the 45 degrees in. Right? So, this is Miss Cheek. She retired. I'm sorry you didn't get to meet her. Hopefully someday you will. She's about 95% heart and love, that woman. So, we want to make sure you're 45 degrees up compared to the maxillary occlusal plane. We want to go 45 degrees in compared to the midline. And then back. Like, don't go forwards, go back. In, up, back. So in, up, and then you're going to go back. And the whole idea is to try to just sneak around the corner of the tuberosity. And then as one of my students said, and then I just kind of aim for the center of their brain. I'm like, yes, that's it. Oh. And hopefully all that adjusting of angles happens outside the tissue. So you can go straight in, straight out. Okay? We want to minimize maneuvering in the tissue on this one. Why? Trauma. What's the major adverse reaction to a PSA? Hematoma. Okay? Knowing where you are, staying tucked in, intimate, not contact, but proximity to the tuberosity, and being able to cruise straight in and straight out really, really, really helps. And knowing your depth. Okay. And then you've heard me say before, yes, your faculty will actually bleed for you. Yes, this injection actually happened. So remember I said that Mrs. Sestero has a little teeny tiny mouth. As much as possible, we want you in 45 degrees compared to the patient's midline. We just literally can't stretch her lip that far. So we do the best we can on her. But as much as possible, we want you 45 degrees in, and then 45 degrees up. We did pretty good on that. So in, up, back. So it's helpful if you go from the corner of the mouth, the commissure, to the ella of the nose. here's the thing. Where's this person's finger?
Right by there.
See how they're a little up with their finger? And that lets your syringe barrel sit at the commissure. If your finger is in the commissure and your barrel is sitting against this side of the finger, you're no way going to get 45 degrees in. Make sense? Can you actually see the picture from the back there? So, you need to retract up and out, both. You want this tissue, see that tissue is really, really extended laterally. It goes from the mucogingival junction straight out. And that gives you a shelf of tissue to be able to inject into. Let's see if I can get back to this guy. So see how it's up and out? And you can visualize the entire buccal of the last molar. There's no flabby tissue laying over there hugging this last molar. So this index finger goes up and out. Your finger itself goes above the commissure. Your syringe comes down to the commissure, and you slip in underneath there. So that way you can have this tissue nice and stretched. You get good visibility. You can get your angle. And with the tissue more stretched, it tends to be more comfortable. PSA is pretty uncomfortable anyway. Okay, so basically we want to be going commissure of the lip to the ala of the nose, and that usually is your 45 degrees. Okay, so here's the best practice. We're not doing this because this scares me because you're aimed back towards the maxillary artery on that guy, and this guy really, if he could get 90 degrees, I don't know. It's partly this person's too low. But who knows what you'll hit there. Ah, scares me. Okay, so again, same deal. Get your topical on the swab. Do your retraction. Come in with your swab tip as if you're doing the injection. See how it's tucked in underneath the person's finger. They've got this tissue draped out really nicely. They can visualize along there. You want to make sure that you curl your index finger a little bit back there, just the tip of it, to be able to pull that tissue out and up. And you need to have a small enough glove so it's not really baggy. So, you know, if I walked around behind you going, oh my gosh, you have to take that glove off, it's too tight, it's like a little hand tourniquet, stop it, then this might be the day for a hand tourniquet. If you're kind of between sizes of gloves. If it fits you pretty snugly, stick with your glove size. If it doesn't fit you snugly, you might want to go down a size just on your left hand, if you're a right-handed practitioner. Okay. 3 to 4 millimeters from the mucogingival junction. So that does not mean up from it. It does not mean down from it in the cheek. It means straight out because you brought that tissue out in a shelf and it's 3 to 4 millimeters away from there. Nice retraction here, and see how we're 3 to 4 millimeters away from the mucobuccal fold, the mucogingival junction. Okay, what do you see any issue with this technique?
It's on, the needle's on the glove?
Needle's on the glove. Yep. This is why, see how this person's finger is really straight? This is why I want you to curl your index finger a little bit. Because it gets the end of your finger away from the glove. Okay? Not only do you fail the injection, but what do you know? You just contaminated the needle that you're now poking into the patient. So let's not do that. Okay. So palpate. If you're having trouble reaching, have the patient close so that their coronoid process goes posterior. Right? Remember in the beginning it's like, oh, I'm trying to see the distal and second maxillary molar. Open really wide, and it got worse. Then you had the patient close up a little bit, like, oh, I can see. It's because the coronoid process is in the way. Stay in real close proximity to the tuberosity. You're going to use your swab tip to decide, am I going to be able to swing past this tuberosity? But really close to it. right? So it depends. Does your partner have a third molar? Did they used to have a third molar and that tuberosity is a little larger? Because they don't totally resorb when they take a third molar out. So you're going to make sure that you're not going to go crashing into their tuberosity. You're going to try to get your angle set up. You're trying to move straight in, up, back 45 degrees without bowing the needle, and hopefully without touching periosteum, and come straight out when you're done. Less trauma to the tissue, less chance of getting a hematoma. So approximately 3/4 the length of a short needle. For most of you gals, I'm going to say 2/3. Right? We could do 3/4 on these guys with the taller maxilla. And there's your script for that. Okay, so for the test, the board answer is always everybody has an MSA. In reality, how many people have an MSA? Less than a third, right? But the board answer is everything but the mesiobuccal root of the first molar. Okay, questions on PSA?
Double aspirate.
Double aspirate. IA. On the IA, double aspirate.
The buccal, double aspirate.
No double aspiration on the buccal. Really low risk. I would double aspirate on the lingual. Okay, palatals. Where are the greater palatine foramina?
Way back
Take
there.
a look at that picture. Do we want to be injecting near the greater palatine foramina?
No,
Because why?
it's not very great. It's the greater palatine artery.
Because why?
You want to get their throat? No.
Yes, because why?
The nerve is right there?
What nerve's right there?
The greater
The
palatine.
lesser palatine nerve.
Lesser palatine,
Oh, yeah.
right? And these are the guys that do their soft palate. Have I had a partner in school do that to me yet? Not real pleasant. So, we're going to use our wooden swab tip. What teeth are we looking to go between?
First two, molar 1 and 2.
First and second molars, right? Okay, so 25 gauge short, patients can't tell the difference. Back in the bad old days before we did, institutional review boards, we did no topical and we did all these different needle gauges. And guess what? Patients could not tell a difference. So that 30 gauge thing is for the mind of the practitioner. It makes no difference to the patient. They can't tell. You poked a hole in them, it hurts. Okay? So, topical pressure anesthesia. It's a whole lot easier with a 25 gauge to deposit the solution. Plus, it's already on there, right? So you do your PSA, your infraorbital, you go back and do your grader. You're all good. Any gauge short needle is acceptable. If you're teeny tiny and you just cannot get a fulcrum, we can look at you using a 30 extra short. So talk to us if that is your experience. Pressure anesthesia, I should see blanching from your pressure anesthesia because you're sitting over the little trough, the little groove here that has not only the nerve but the blood vessels that come up that way. And you're going to walk back, and I usually start the mesial of the first molar and I just walk back to the distal of the first molar, and somewhere right around there I should slide into that little trough that's right ahead of the foramen. So, that foraмен's back there. We're not going back there because we don't want them to have their palate numb. We're going to touch in the base of that little bony trough that's anterior to the foramen. And so it's between the first and second molar, and it's halfway between the midline and the gingival margin. And I think of it as the corner of the palate. Not everybody has a real square palate. Some people are more V-shaped or very U-shaped. But you should be able to visualize that halfway mark.
Would a large tori for this one be one of the things to talk to you about?
I have never had a tori so big that I couldn't get a GP. I've had them kind of close to where the GP was, but you have to think, where's the midline, and visualize. And that is your spot, right in front of the swab. Right in front of it. Don't touch the swab, but where is it now? Right next to the swab, right? In the area of blanching, So if you're 3 millimeters away, your pressure anesthesia is doing you no good, and you're in the wrong spot. Okay? I tend to get the swab a little juicy with topical, so that when I palpate, I do it with the topical. I start at the mesial, the first molar, and as I palpate back, what do you know? I'm applying topical across that whole area. So then when I find my spot, I can just sit, and there's already topical on there. I'm taking every opportunity to make this as comfortable and pleasant as possible for the patient, least unpleasant. Okay, so if you are doing your dominant side, then we're going to sit at 9. You're going to have the patient really, really flat, supine, supine, supine. They're going to chin up a little for you. You're going to get a fulcrum over here. So 12, 13 if you're right-handed, 4 or 5 if you're left-handed. Get yourself a fulcrum, and then you can just mirror that on this side. So the grasp is really similar to an IA. That palm up, stick your pinky out, touch the opposite side of their jaw, opposite side of their mandible. It's going to bring you contralateral the way you want to be. Why are we going to be contralateral?
So you can see.
So you can see. What else? So that you are coming through as little tissue as possible. Okay, so you don't want to come ipsilateral the same side and penetrate here and slide across their palate, right, to get there. You want to come straight through from the other side and go through somewhere between 3 and 5 millimeters of tissue usually, and you're there. Yeah.
Where would the bevel be facing?
So the bevel is going to be facing towards you pretty much, because as you come up, you want it to touch the palate this way. Okay. So IA. Bevel facing which way?
Back. Away from you.
Towards you for the IA. Because we're doing our side, right? Buckle, I don't care, touch gently. You don't have to go in there and change your bevel. Greater, facing you. PSA. Kind of away and up. Yeah. Okay, naso. Facing you. So mostly facing you with the bevel. Okay, so again, there's your spot. Just anterior to the swab, in the area of blanching that you walked over with topical, so we're as numb we can get the patient. And there's your script. Palatal gingiva, third molar to first premolar. Okay. Questions on the grader? All right, naso. So, have y'all seen the little parentheses? At least one person. The little grooves on the side of their little incisive papilla. Okay, we're going to think about turning that into thirds. Anterior, middle, posterior, third. You are penetrating at the junction of the middle and the posterior 1/3, 2/3 of the way back. Here's the deal. If you're way back in the rugae back here, no. If you're way over here in the rugae, no. If you're way towards the teeth, no, because think how little tissue there is that you're going to try to cram a quarter or an eighth of a cartridge of solution in. Right? So, think about where that is. When I put my pressure anesthesia on here, I want my swab to sit on this other side. I want my fulcrum, I want modified pen grasp, not this, whatever that is. I want modified pen grasp, and I want to be like on number 11 for this one. And I want to be sitting with the swab so I can see the little side of the parentheses that's facing towards me. But I want as much coverage with topical and pressure anesthesia as possible. So I want to be right on the area, so the foramen is right under here. I'm going to be putting that pressure anesthesia on. And I want to not have to move my topical and pressure anesthesia at all. So before you do a palatal injection, you're going to have your swab in your hand, but what else are you going to have?
Your
Your syringe. Where's it going to live? You're going to rest on the tray somewhere. What's the important thing if it's resting over there on the tray in space? Right? Don't have anything in the way. That cup that you had with the 14 needles in it, because you were nervous, or the 4 extra cartridges, at least live somewhere else in the clean spot, right? Don't have a bunch of stuff on your tray. Have your hand facing so the needle is hanging a little bit off the tray into space, not so close so that if your partner decides to scratch their nose, they'll impale themselves. Okay? So, ready? You know, you've already looked once. Get your really good pressure anesthesia. Have a good fulcrum, modified pen grasp with your wooden swab tip. Sit there for how long? At least a minute. Could be 2. And be in position so that you can just pick up your hand and go and do it without losing your pressure anesthesia. There was a question.
The pressure anesthesia, is it on the foramen?
Yes, because the foramen's right at midline.
Okay. So
And you're injecting just
outside of it.
Just outside of it. And you're angled underneath it. Okay, so one of our formal faculty would say if you had a little grain of rice sitting on the tray, the whole idea is to try to get right underneath the middle of it. That's where the foramen opening is. Do we need to touch periosteum for this guy? Nope. So if you go in there 3 millimeters and the pupilla is 6 millimeters wide, please stop. Okay? I just want you hovering over the foramen. If you do touch periosteum, the world is not over unless you're touching periosteum over there, then do lateral. Okay? Just concentrate in the right spot. Get the bevel in. Anesthetic pathway. As soon as the bevel is in, start giving some drops. Okay? So pressure anesthesia, bevel in, doing the anesthetic pathway all the way in, really, really critical to making this comfortable. Okay, and there's going to be your little spot, and then there's your stuff. So, super periosteal. Do you need to go over this?
Yes, I've never even done it.
Okay. You've done an MSA. I'm sorry, an ASA. Lost my mind again there for a minute. And an MSA. So what do you know? Go a little less far. You do want to be just above the apex, right? And how much are we going to give on this one? 1/4. Okay. So, going to have a really good fulcrum still. We're going to really retract the tissue. All those good things. I like with the PSA to have my thumb and my pinky together, so that I can easily, if I'm doing a PSA, I can easily place topical for a PSA and an infraorbital at the same time. And we practice that way in lab. And you can angle one direction for your PSA, and you're hugging the lip with your middle and your index finger, and you just rearrange where their lip is, and you go on your new adjustment of your fulcrum and do your next injection. Saves a whole lot of time. So, you're going to touch just past the apex of the tooth to be anesthetized. Aspirate, inject, quarter cartridge of 1 cc over 1 to 2 minutes. So it should take at least 30 seconds for that quarter cartridge. Shouldn't take 5 minutes. Should take 30 seconds. Okay? To you it feels like 5 minutes. Okay, the backing off periosteum. So I see this mostly on IAs. I've touched periosteum, or I've stepped off, now I'm going to back off, and you come out like 4 millimeters. Palatals is the worst. Oh, I touched periosteum, I'm going to back off. Pretty much don't cram it on the periosteum, but you know, as you aspirate, it'll pull you 0.5 millimeter off the periosteum. Please do not pop out of tissue. That's no bueno. Okay? Nobody wants to get poked the second time.
Wait, you aspirate on the palatal?
You aspirate on the palatal, yes. You'll be aspirating on everything. Always aspirate on everything. Remember me talking about you drive to school or work and you're like, I wonder if I stopped at that stop sign. That feeling? It will happen, I guarantee you, with local anesthesia. I know you can't imagine that yet. But if you just aspirate every single time, then guess what? You aspirated.
So when in doubt of like, am I supposed to aspirate? Aspirate.
Just aspirate. Okay? So, when do we aspirate? Right before we what? Actually deposit the injection, right? So don't get half a millimeter under the tissue and go aspirating. Why are we aspirating? We're not there yet, right? Get there, aspirate every time.
Aspirate, quarter turn, aspirate?
Yes.
Every time? Isn't that just like on a
So double aspiration, what injections?
ESA? Just those two double?
Yep.
Okay.
Okay?
Okay, and if we get a positive aspiration, then we just back off?
Yeah, so you're going to decide, should I pull out a millimeter or two, probably 2 millimeters, aspirate again? Do I need to totally reposition? You'll evaluate. Don't panic. Don't panic. Everybody needs to hear this. And pull out of the tissue. Okay? Positive aspirations happen to excellent hygienists doing textbook technique. Do not fly out of it. Oh my God. Woo. Don't freak out. It will not mean you fail. It's just a normal thing that happens. So, positive aspiration, we just want you to know how to handle it. Because they happen in real life. So yeah, come out a millimeter or two, aspirate again. Double aspirate if it's one that you need to double aspirate on. And move on with the injection.
So for the first aspirate, it's positive, so it's red there then.
Yes.
If I go back and then again, so an aspirate, so I can't figure it out. It's
So what's your decision making process on that? You had a positive aspiration.
How much?
When do you have to change the cartridge?
How much blood there's in it?
How much blood there is. So, if you are aspirating right now so hard that there are air bubbles streaming into the cartridge, what are we doing? Okay? Where do you think the air comes from? Is there air inside their vein?
No.
Is there air inside their tissue? No.
It's from before you go in and holding it.
You were pulling so hard that you were sucking air through the diaphragm around the needle. Too hard. You don't need to do that. So if you are having that problem, I would like you to go upstairs, get one of those little cups, put a little disclosing solution in it, get your syringe out, get rid of a little local anesthetic, stick the needle into the blood vessel, and see how lightly you can pull, and see a little puff of disclosing solution. You'll be amazed at how little pressure it takes. So that's one of the things that we see is people are trying to aspirate so hard, they're pulling out of tissue, they're popping off their fulcrum, they're sucking all this air into the syringe. It's making you move a bunch so that you're in the palate and you're trying to hulk out this aspiration and the patient's dying. So a little pressure.
Well, if your first aspiration is negative, but your second is positive.
And your second is positive, then what?
Then you just do another turn?
Then you back up. Millimeter or two, get to a new little area of tissue out of that blood vessel, aspirate again. Okay? And as long as you can still see to evaluate it, we're okay. You can just continue with the injection. Now, in the rare, very rare, it has never happened to me personally, instance that you get into an artery and and it's just red, that's really, really rare. Then, obviously, you can't see. Judgment call, I'm out because I have no idea what's happening now. Plus, I probably need an ice pack and pressure on this patient. Okay. Questions? Any more on? Yeah.
I guess it's not on this, but, or maybe it is. So when we turn our syringe, we turn it so that our palm is up, right?
So it depends. If you start and your palm is up already,
Yeah.
then which is going to be the easiest?
Down.
It depends. Some people need to turn a little more away, some people towards. How do I decide?
That's above. Yes.
Nope.
I don't know.
If you're the patient and there's a needle in your tissue, and the operator has to move it, how do you want him to move it?
Out. Yeah.
The most steady, right? So what's the point if I go in here, right, and I go in and I'm trying to decide, okay, one aspiration, and then I do something like this with my hand. Is my second aspiration going to be negative? If I just egg beatered the tissue? Probably not, right? Whatever fulcrum allows you to stay on that very same plane and at the same depth. So it's not looking like this anywhere. It's just, I got my fulcrum, I can roll a little towards me, or I can roll a little away and keep it on the very same plane, the same depth. That's how you do it.
Okay.
That second aspiration should not be positive as a result of trauma to the tissue.
We get marked off if we don't roll the thing,
You have to roll it a significant amount. Does it have to be a whole half turn? No. Please don't do that.
Okay.
Do it the little quarter turn. That's it.
We roll a little quarter turn.
One way or the other, whichever's safer for the patient.
And we aspirate.
Uh-huh.
And then, it's negative, and then we inject.
Yes.
I mean,
Thanks for bringing this up. Here's what I've seen. I've touched. So I'm at my deposition site. Quarter turn, aspirate, quarter turn, inject. Don't do that. Okay? Go in, find your spot, touch or whatever. Aspirate. Tell me I'm aspirating while you do it. My aspiration is negative or whatever it actually is. Roll, aspirate again. Do not roll back. Stay right there. Deposit.
well, what if the bevel isn't towards the bone?
It's okay. The bevel towards the bone is two things. Being nice to the bone if you touch it. And if you're using a consistent angulation of your bevel, what does that do about your needle deflection? Consistent needle deflection. So whatever technique you have is going to be more consistent if the needle's always pointing the same way, because it's always going to deflect about the same way. And that way you won't be like one day it goes left and another day it goes up. Make sense? Touch, aspirate, aspirate, quarter turn, aspirate, and just inject. Don't move when you have your negative aspiration.
So for the testing, we're going to be depositing the full amount this time?
We'll have you tell us.
Okay.
Because I think it's mean otherwise. Okay, so expect while you're in the tissue to be able to say, I'm depositing. You're going to demonstrate a good rate of deposition and that you're steady. You're not on the PSA depositing and in the meantime also hubbing your needle. You're not depositing on the pallet and pulling the needle out of the tissue accidentally. Things like that. And then at a certain point when you feel like you have a good, consistent, yes, I can see you can deposit at the correct rate, stop there, tell me how much you would normally deposit. We'll go on from there. Because I want you to have lunch or dinner. Okay, you're welcome. Okay, supraperiosteal will be on the maxillary. All the injections we do will be on the dominant side. I do not want you to go home with crosswise anesthesia. That's not nice. This is your script for the infiltration. Okay, so process of the test. Arrive early, really early. If you drive here, you don't just walk across the street. If you drive here, come early. Review your patient's health history and take your vitals before you guys start. You'll notice on the schedule there is a report time, a setup time, and a testing time. And it's 15 minutes, and you should be able to do this in 15 minutes. If you can't do this in 15 minutes, come 20 minutes early. If you can't do it in 20 minutes, then come sooner than that. We're going to be doing one half of the clinic and then the other. Okay, so you should know whether local anesthetic with vasoconstrictor is contraindicated. Are you going to be doing any work with this patient with their numbness?
No.
Then is the vasoconstrictor indicated for this patient?
No.
Correct. If I look down and you have lidocaine in there, that's not nice. And it's not the right drug for that patient. Okay, so you're going to tell us, I'm doing this PSA, I have 3% Policaine plain, I have a 25 short, try not to use the dental N-word needle, just have a 25 short. These are my landmarks. Here's what I'm palpating. I'm penetrating, I'm advancing, I've touched, I've reached my deposition site. Talk to us. I feel like the small child in the back seat of the car, right? Are we there yet? Okay. You're trying to think, I'm like, just please tell me where you are. Please tell me where you think you are. Okay. I'm aspirating. The aspiration is positive or negative. Quarter turn, I'm aspirating, positive or negative. Afterwards, you're going to tell me regions of anesthesia. Some people want to do that beforehand. Mostly, if you talk yourself through the procedure, it helps. I tend to have you tell me after what did that anesthetize when you're like, whew, done. Okay, so this is my penetration point. This is my deposition site. I'm aspirating. Aspiration is I'm depositing. Why am I making you talk to me at these 5 spots? Because if you decide to take the Reb anesthesia exam, they're going to make you tell them these 5 things. So it's just going to be practice for that. Plus, I'm like the kid in the backseat. Are we there yet? Okay, so this is my penetration point. Go in, get to your deposition site. I'm at my site of deposition. I'm aspirating because I want to see that happen for sure. Don't tell me later, but I did it, but you didn't tell me, so I didn't see it. I can only grade what I see. My aspiration is whatever it is, I'm depositing.
You said we decided to take what anesthesia test?
Reb, Western Regional, remember what the E stands for, examination or something.
So it's not like mandatory?
It's not mandatory for California.
Oh, but we...
So, but you could decide to take it. Anybody live in Washington or Oregon? Right? So if you're going back, Washington or Oregon, you'll take the Reb exam. It depends on the other states. Idaho makes you take it. I know because somebody retired from here and went there. Okay, so you're going to palpate and you're going to wipe the tissue gently. Gently. Sorry guys, I try not to say the sexist. Don't manhandle it. Don't woman handle the tissue too roughly. Okay, minimum effective dose. It says full recommended amount, but we're not going to do that to you. But know the correct dosages. You're going to know to replace your needle if you contaminate it. So again, this is not a failure if you figure out you touched something with your needle. Glove, PSA. You're just going to say, I contaminated my needle, and you're going to change it. Okay? You're going to know to redirect if your aspiration is positive. You won't freak out. You'll just handle it. You are going to do one-handed scoop technique using the safety shield. Anytime you come out of the mouth, I promise you, your patient will not drown in the 30 seconds or less it takes you to get the needle tip into the shield. Then your non-dominant hand comes and touches where?
The end of
The cap only, no cardboard. No touch of the cardboard. And snug it up, set it down. And then, yes, rinse and suction the patient out.
So you can touch the cap. Just
The
not
cap.
the board.
After what?
It's in.
So you don't have to...
After it's in. I want that needle in there, safe. I love you. I do not want you to go get stuck anywhere, right? I'm not worried about your partner. I'm just worried, oh my God, the 2 hours of your life that you won't have back because we had to do blood draws in the emergency room. Hello, Explorer stick this year.
So all the professors know that after the needle is in the cap, we can go ahead and
Yes.
touch the cap up.
So not touch the cardboard.
Okay.
You
But
can-
it's still considered a one-hand scoop if you touch
Yes.
the cap.
So here's a one-hand scoop.
Okay.
Here's the cap sitting on the tray. This is what we used to do.
Yeah.
One-handed scoop and
Oh,
then
always-
recap it. We don't have to do it anymore.
Yeah.
You just get it in there, and then you can reach from the other side and touch it.
Okay.
Is there confusion about that?
I think we're confused one-handed, if we could touch
I
the
thought you'd
cardboard,
be-
we're just kind of like following
No
it.
touching
falls
the
off.
cardboard.
No, touch the cardboard.
In there, one-handed, then your other hand can come and tighten it up.
I was told just to like only touch it. Like prop it in the cap a little bit.
Don't just prop it in the cap, because it's loose, it's not safe.
Yeah.
You have to snug it.
Okay, so.
I have seen people do the gymnastics of go into the cap and then like stand it up and one-handed. That's too much. You can use your other hand as long as the needle's inside the cap, as far as you can put it, and then snug it up. No crazy gymnastics that you could slide around with. Okay? So here's the deal. Since we're doing Reb anesthesia rules, you get up to 3 penetrations. What's a penetration? You had to actually come out of the tissue and start over. You can walk around if you have to get into a good position. If you are macerating the patient's tissue, we will stop you. Right? If it's a few steps for the IA, okay. Happens on clinic all the time, in private practice. Great clinicians have to sometimes walk some. But if you're like fishing around, then that's a no. You get 3 chances to get there, right? So there may come a time when you say, oh, I'm so far off that I have to repenetrate. And that's a way better decision than trying to walk a half a mile to the IA. Okay? So, be thoughtful. Think about the fact that your partner will eventually not be numb anymore and will feel the effects of what you did while you were in there, getting them numb. Okay. Okay? Please. By the time you're a senior, it'll be like, yeah, it's that stupid slide again. But please, ergonomics, if you're not in a good, safe ergonomic situation, it's not going to go well. So, you got to have a fulcrum with your finger, non-dominant hand, somewhere you need a fulcrum. So if you can't get a fulcrum yet, come this week is your week. Get that straightened out. That's on you guys. Okay, if you arrive late to the test, you fail. Now, if you call me from the freeway and you texted me the pictures of you in the 3-car pileup, that's a different story. If you're vomiting your brains out, bye-bye. Don't share. Don't want that, right? So, if there is a reasonable reason that you're not there, we're going to go with that. But if you slept in because you didn't set 3 alarm clocks, sucks to be you that day. Okay? So, show up. If you don't do your health history review or vitals, if you contaminate things and you don't recognize it and you're just ready to get that dirty needle in the patient, that's not okay. If you can't figure out the landmarks, the penetration point, the correct pathway of the needle, obviously you need some more love. We can't pass you on that. If you forget to aspirate, that's not safe. We can't do that. If you don't see that you have a positive aspiration, that's an issue. If you don't handle it correctly, that's an issue. You got to know which regions of anesthesia each injection anesthetizes, because we need to know that you know the correct injection to choose to get what you want numb. Okay? And you're making a legal record, right? This is one of the riskiest things you ever do. You need a correct legal record for that. So all of those would unfortunately be failures. So, just like lab, you're going to say local anesthesia lab tracking code, and you're going to attach your template note to that. So just like we've done for every lab. You're going to calculate and record the milligrams used. Not the amount that you would use if we made you do the whole amount, the amount that you actually deposited into your patient. And then you're going to put down any adverse reactions. Now, strictly speaking, positive aspiration is not an adverse reaction. But I want to know that it happened for myself in my long-term memory, and I'm going to make a note about maybe why it happened. So I have given one hematoma in my life. It was on an infraorbital. Oh, it was pretty. right? Black eye, and yeah. So I thought, okay, well that was interesting. Made a note of it about it, obviously. One more time, I did an intraorbital on that gal and got a little tiny positive aspiration. Like, yeah, if you have a little artery there that is in a really different spot, done with that. We're doing another intraorbital on you, right? So we need to know what happened, how'd you handle it, what happened with the patient. Just the fact that you got a positive aspirin does not mean that they're going to have a hematoma. But if that happened, obviously I would like to know. And, you know, just if it came out fine, then we just need to know it came out fine. If you can't reach the landmark because of some reason, if you did get a hematoma, if you had no adverse reaction, you could say positive aspiration, repositioned, obtain negative aspiration, proceed with injection. NAR, no adverse reaction. Okay, but that's got to be in there every time. Okay, here's the other part of it. I'm going to hand you a paper. And I'm going to say, tell me 3 contraindications, absolute contraindications to vaso. So you have Mrs. Hayton's list, yes?
Yeah.
3 absolute contraindications to vasoconstrictor. Tell me 3.
Uncontrolled hypertension,
Uncontrolled hypertension.
angina, recent drug use.
Angina, recent drug use, what else? Uncontrolled diabetes. Congestive heart failure, uncontrolled. Okay, uncontrolled. Hear the word uncontrolled.
Anything uncontrolled.
Things that are uncontrolled. Okay. Tell me about thyroid.
Thyroid storm.
Thyroid storm. So that's uncontrolled what? Hyper. Do I care about hypo?
No.
Why not?
She doesn't raise
Right?
heart rate.
It's not going to raise your heart rate and your blood pressure and all the things that we're worried about with vasoconstrictors. So hyperthyroid, uncontrolled. Okay. Yeah. Let's see. Did I have this on here? Nope. Sorry, this is an older list. Darn. Sulfite sensitivity, especially in people with asthmatics. What's not on here is glaucoma. So go with Ms. Hayton's list. She helps me grade this. But we know now glaucoma, we don't do that because it can increase their increase their intraocular pressure. Okay, has to be clinically acceptable, so no critical errors. She didn't drop the syringe on the floor, pick it up, and put it in the patient's mouth, for instance. You didn't have a whole bunch of multiple less critical errors, like up, down, in, out. Right, that doesn't go well. Safe and effective overall technique. Patient comfort and safety. Under professionalism, openness to learning, professional demeanor, composure. Clinic attire, including appropriate personal protective equipment. Maintains asepsis. Anything with a star is critical. But if you can't put the syringe together still, then I'm going to be worried. I've had that happen before. You notice that obtains profound anesthesia is not a critical error, because guess what? Some days I don't get there either. Okay? We get really used to doing this all in the patient's face. Please don't do that in the patient's face. Turn away to adjust your bevel, right? Start practicing that. Because you're used to, okay, so the bevel goes this way. Let's not do that. Okay. This is the updated cheat sheet. Y'all should already have that in your clinic binder. If not, shame on you. And do it now. And then here's your dosage thing. And all those basics things in the clinic course. Please go back and review them. So IA, PSA, what else?
Greater nasopalatal.
Nasopalatal, greater naso.
And greater palatal. And
Superperiosteal. Also, please, ergonomics and safety. Anybody know what this is?
Mosque where?
Oh, that's the blue mosque.
So this is Hagia Sophia, which is the basilica that was turned into a mosque, and now it's a museum. And oh my gosh, it's amazing in Istanbul. This is my dad. Probably 8 years ago. So there's the blue mosque, and there's the blue mosque. It's amazing. It was like, I know it's probably not respectful, but can I just lay here and look at the ceiling? This one you might get away with laying down there, but yeah. So I was an art major before I was a hygiene student, and oh my gosh, like this was like walking into St. Peter's, because none of these places did I think I'd ever get, and I kind of burst into tears and oh my gosh, I've seen these things in person. So that was one of my awesome moments. Please travel if you have a chance. This is the this little grotto underneath the city. So because between Europe and Asia, right, 4 billion times they battled over Istanbul, Constantinople. So this underground water storage helped them resist sieges. So if you look, parts of different Roman temples have been used to make some of this. So now, of course, they put fish in there and they charge people to paddle through. A little romantic boat ride through and the spice market. Oh my gosh, this is amazing. Oh, yes, and we went to what probably is Troy, and so were the windows not maybe you can see the guys through the window. This is a handicapped ramp in Turkey, just so you know.
Wow.
Really helpful. And my favorite, the genuine fake watches. Okay. Thank you.
Thank you. You have to print out